Thank you, Dr. Beer, and once again, thanks to the organizers for this wonderful meeting and for including me, and particularly for asking me to speak about this topic. I think this is a very important topic for the region, because when we go to conferences about pediatric glaucoma, and when people speak about pediatric glaucoma, they tend not to speak about deep sclerectomy. But in this region, deep sclerectomy has really come on its own as a procedure for primary congenital glaucoma. And I have to say, I myself would not be talking about deep sclerectomy had I not spent time in Saudi Arabia and learned from my colleagues such as Dr. Ibrahim Al-Jadan and Dr. Saleh Abedan in Riyadh about how this procedure can be useful for pediatric glaucoma. I have to say I was probably one of the most skeptical people about it, but I have seen results and I myself use it in my armamentarium for pediatric glaucoma. So the classic initial surgeries for primary congenital glaucoma, as we heard from Mr. O'Keefe, include goniotomy, trabeculotomy, and combined trabeculotomy-trabeculectomy. Over the last several years, however, deep sclerectomy has gained favor as an initial surgery for primary congenital glaucoma in the Gulf region. One of the major advantages of deep sclerectomy is the low risk of postoperative complications because there's no ocular penetration when it's done properly. However, there is a learning curve for proper dissection, particularly when you have advanced disease. So, in the normal angle, we have the ciliary body producing aqueous. It flows and drains through the anterior chamber angle. The anterior chamber angle, the normal angle, when we look at it gonioscopically, we see the ciliary body band, the scleral spur, trabecular meshwork, Descemet's membrane. In classic primary congenital glaucoma, we typically have trabeculodysgenesis, where the iris inserts anteriorly, and we don't have a good view of the ciliary body band. Actually, we don't see it at all. And often we see small iris processes visible on the trabecular surface. So classically, to address isolated trabeculodysgenesis, one of the first procedures described, goniotomy, where under direct visualization you make a slit and open the angle up, as illustrated in this drawing and in this photograph. Trabeculotomy is the same concept, but from an external approach, where we make a flap, bring in a Harms trabeculotome through Schlemm's canal, bring it into the anterior chamber, again opening up that dysgenic angle. And then the combination of trabeculotomy, trabeculectomy with or without mitomycin C, which is a trabeculotomy combined with a trabeculectomy, a procedure that most of us are already familiar with. These are the three classic procedures for primary congenital glaucoma. Now, deep sclerectomy is a different approach, and I don't know what happened to these arrows. They became very big, but what is happening in deep sclerectomy, you're removing a portion of sclera just peripheral to Schlemm's canal and cornea. So you leave a Descemet membrane, you leave a thin membrane of trabecular meshwork / Schlemm's canal and a thin membrane of Descemet membrane through which fluid percolates. So you're removing a block of sclera deep in the ocular wall. And the way we do this is from an external approach. First, we make a flap, as you would in a trabeculectomy, but then a second flap is made just over the ciliary body, and you dissect anteriorly, unroofing Schlemm's canal, going on into cornea, and just leaving a thin membrane, Descemet's membrane. Once this second flap is created, it's amputated, and you see this nice percolation of fluid, not gushing through, but percolating. And it's almost like a valve mechanism. You then close the upper flap, you have a little bit of a lake there, and you have this percolation of fluid. You have not penetrated the eye, but you have created a valve-like system where fluid is exiting. And here you can see in an older child a UBM image of what's going on. Again, you know, there's this thin trabecular meshwork / Schlemm canal membrane going on into the cornea. Fluid is percolating through that, and that area where the deep flap was removed, there's a little bit of a lake there. It's almost like a reservoir. And this fluid, you know, goes and drains into the venous system of the eye, and it provides filtration. Again, you know, it's really, I learned this from my colleagues in Saudi Arabia, and this article by the group in King Saud University in Riyadh is really the first major publication that describes how deep sclerectomy can be used in childhood glaucoma, the type of childhood glaucoma that we face in the region, which is different from the childhood glaucoma that's faced in Western populations. So here's a 4-month-old boy, cornea is mild haze, enlarged, he has IOPs in the mid-20s, discs, he has vertical cupping in both eyes, he clearly has primary congenital glaucoma. I did superior nasal deep sclerectomy in both eyes. You can see the slightly raised conjunctiva there. For years now I've been following him. His IOPs remain in the mid-teens, his corneas have cleared up, and the cups have reversed. We can see reversal of cupping if you treat congenital glaucoma early enough and you get the pressure down. Here's another 4-month-old boy. He's got unilateral glaucoma. His cornea is enlarged. IOP is 29. He has vertical cupping, deep sclerectomy in that eye. Pressure has come down to 10 with corneal clouding, or with corneal clearing, sorry. And there's about 6 months follow-up for him at this point. This is a child who was referred to me for a valve, Ahmed valve. He's a 15-month-old boy. He had prior glaucoma surgeries in both eyes, both quadrants. The left eye, though, the IOP remains 55. He had superior nasal surgeries in both eyes. He's referred to me for a valve. It is something that I would have put a valve in previously, although I really don't like to put valves in young children because they tend to migrate, and you have to follow them very closely. I decided to attempt at least a superior deep sclerectomy in him. So this eye is really, it's buphthalmic, so you have to make the flap much larger because the anatomy is completely distorted and things are more posterior than you expect. So the initial flap is there, and now a second flap, and you can see here when you unroof the area of Schlemm's canal and trabecular meshwork, you get this percolation of fluid, and it's not gushing through, it's not a penetration. And you can see when I wipe it with the Wexel, it stops. And then when I remove the Wexel, again, it comes slowly. It's a beautiful sight when you see that fluid flowing there. And again, this is much more posterior than you would expect in a regular case because of the distorted anatomy. And so, you know, with this procedure, his pressure came down to 20, which is acceptable for this child and can be supplemented with medications. And we can avoid putting in a valve, which is really not a trivial thing in a young child because of the follow-up that's required. So to summarize, deep sclerectomy has a role in the Gulf region. Really, the low risk of post-op complications is what makes it so appealing. However, it is something that requires a bit of a learning curve, but with the learning curve, it is a procedure that has a role for the primary congenital glaucoma that we see in the region. Thank you.